Dr. Basil and Mathew, Assistant Professor, Department Pedodontics, Vinayaka Mission, Shankaracharya Dental College. Today I will be taking a class on dental anatomy and histology. In this, today I will be dealing with eruption, shedding and chronology. So eruption and shedding will include the eruption of deciduous teeth and shedding of the deciduous teeth, continuing with the eruption of permanent, and then the chronology of eruption of the permanent as well as deciduous dentition. Now coming to the contents of this class, first I will introduce what is the significance of eruption, shedding. Then I will be dealing with some topics under eruption, that is pre-eruptive movements in eruption, eruptive movements and post-eruptive movements. After that there will be some theories of eruption which will explain how the eruption is happening and how the tooth is erupting from the dental crypt to the oral cavity into the position of occlusion. Next there is chronology of eruption will be dealt, and shedding, which is a very small topic where the pattern of shedding will be dealt in detail. Now coming to the introduction of eruption, eruption can be called as an initiation and eruption which is initiated by the presence of certain factors within the bone. Then there will be an eruption of the teeth which starts from the bony crypt, and the tooth will end into the oral cavity in an occlusion or a functional position. Now it can be defined as the process by which the tooth moves in an axial or occlusal direction from within the jaw into a functional position in the occlusal plane and maintains its position throughout its life in the oral cavity. So when you see the slides, 2 points you need to be careful about is, one is delayed eruption and the second is retained tooth. So delayed eruption, what does that word signifies? Delayed eruption, for example, if you see a tooth in a oral cavity, that is 6-year-old child, if a permanent first molar is not present, it is normal, whereas in a 7 or 8-year-old child, if you don't find a permanent first molar, you can call that is a delayed eruption of the first permanent molar. Whereas in the case of a retained, if I explain it, when you look in a child of 8 to 9 years or 9 to 10 years, if you find a deciduous central incisor, upper or either lower, it can be called as a retained. Retained means it was supposed to exfoliate and a permanent successor was come, but the predecessor didn't exfoliate. So that is called a retained deciduous incisor. Coming to the next slide in detail, first we will deal with the phases of tooth eruption. As I already told, there is pre-eruptive, eruptive and post-eruptive phase. So pre-eruptive is within the tissue when the tooth moves from the place of initiation. Before the eruption begins, it will be moving based on multiple reasons like nearby tooth bud or bone resorption, etc. Then there is an eruptive movement, that is with the initiation of root formation. As and when the root formation is initiated, then till the tooth reach in the functional position, it is called as eruptive movement. It can be divided into intraosseous and extraosseous movement. Whereas coming to the post-eruptive, that is after coming to the oral cavity or into the occlusion, how it maintains its position in the occlusion, that is called as post-eruptive movements. It is done in order to compensate the jaw growth, in order to compensate the occlusal wear, then the proximal wear. Now coming first point, that is pre-eruptive phase. Pre-eruptive phase, the factors that determine the pre-eruptive phase, that is within the jaw where the tooth has not yet started its axial movement towards the occlusion or the oral cavity. The factor determined is the crowding, the jaw growth, and there is resorption and deposition of the bony crypt. For example, if there is a resorption in the mesial side and deposition in the distal side, the tooth bud will move towards the mesial side. And if there is a resorption in the occlusal surface and there is deposition in the gingival surface, the tooth bud will move occlusally. And there is a final positioning of the deciduous or the permanent tooth bud after this pre-eruptive movement, and that is the position where the tooth will be starting its movement axially. So that is pre-eruptive movement, and the tooth is still in that crypt position where it is initiation has happened. Now in the pre-eruptive movement, there are a few points that we need to take care of. That is the position of the tooth bud. if you see a permanent anterior tooth bud, it is always present lingual to the deciduous anterior tooth bud, as you see in the picture on the left side. You will see the permanent successor or the tooth bud is present lingual to the deciduous tooth bud. Whereas in the case of a premolar tooth bud is exactly present under the roots of the permanent deciduous molars. So from there it will start erupting. Whereas in the case of molar tooth buds, the permanent molar tooth bud is present distal to the deciduous molar tooth bud. So this is the important factor that has to be taken care in the pre-eruptive phase, where the tooth to be erupted will assign a position according to this, which I told in the zone, and then it start a eruption later. Now in coming the eruptive phase, we will understand how from there the tooth is erupting into this oral cavity. In the pre-eruptive phase, this is the conclusion of whatever I told. In the pre-eruptive phase, you will see that molar tooth bud is distal to the deciduous tooth bud, whereas in the incisor it is present in lingually, whereas in the premolar area the bud is present right under the roots of the deciduous molars. So this is a clinical example for the same which I told. As I told, the permanent incisors will erupt lingually. You will see the permanent incisors which are erupting lingual to the deciduous incisors, that is lower or mandibular incisors, what you are seeing in the clinical picture. Now coming to the eruptive phase in detail, the picture that is shown is a gubernacular cord or a gubernacular canal. So what is a gubernacular cord or a gubernacular canal? It is a pathway for erupting the dental follicle that will lead it to eruption. So that will decide the path from where the tooth is within the bony crypt and where the path that it has to select so that it will reach the intraoral or the mucosal surface. So it is a fibrous connective tissue that connecting the follicle and the oral mucosa, and it guides the tooth, and once the tooth has reached the oral cavity or the mucosa, what will happen? The cord will degenerate and it is left as a gubernacular canal in the skeleton or the bone. So you will find in a patient all the teeth has erupted, you will find a gubernacular canal rather than gubernacular cord. So that is one point that you need to understand in the eruptive phase. Next, there are some stages within the eruptive phase. If you see into this picture, there is a penetration of the bone, which is done by the tooth bud or the crypt. As it moves up, it will contact the oral epithelium in the oral cavity. Then there is a fusion with the epithelium. When you see there is a fusion with the epithelium, this is in order to make the least amount of bleeding so that the tooth will erupt into the oral cavity with least discomfort to the patient. So there is fusion with the epithelium, then there is thinning of the epithelium, that is oral cavity epithelium. Then finally there is a rupture of the epithelium, and you can see the cusp tips of the tooth into the oral cavity. From there is crown emergence, and finally the tooth is in occlusal contact, or is in contact with the opposing tooth. If it's in the maxillary, if the maxillary tooth is erupting, it will come into occlusal contact with the mandibular, whereas mandibular tooth is erupting, it will come into the occlusal contact in the maxillary. So this is the stages in the eruptive phase. Now eruptive phase, there is one more thing that you need to note. Based on the stages, there is rate of eruption. So eruption rate can be 2 as it is normal within the bone, the eruption will be slower, whereas in the oral cavity or extra osseous, that is in the gingival phase, it will be faster. If you see in the intra osseous phase, it is just 1 to 10 micrometer per day. So that we can imagine how much time a tooth will take to erupt from its bony crypt to the oral cavity. Whereas once the bony wall is resorbed, the eruption becomes faster, and the extra osseous phase is almost 75 micrometer per day. Now coming to the post-eruptive phase, which is when the tooth is in the oral cavity and it accommodates for the movement or accommodate for the growth, accommodate for the occlusal wear and everything. So the points will be the post-eruptive phase. First is accommodation for the growth. So when you see in a child whereas between 14 to 18 years, there is a maximum changes in the growth of maxilla and mandible is seen. So the tooth will manage by itself to keep up with an increase and decrease or the change in the jaw height as well as the length of the jaw. Next is compensation of the occlusal wear. You have heard about bruxism or any normal occlusal wear. In deciduous teeth, as the enamel is very thin, the occlusal wear is very common. If the patient is having bruxism, it will be more severe. So it is mainly done by the deposition of cementum and the apical region so that the tooth will maintain the occlusal wear. Next will be the accommodation for the interproximal wear. That is, interproximal wear, for the classical example is in the case of a caries, that is class 2 caries lesion. There will be loss of tooth structure, and this has to be compensated by interproximal movement or mesiodistal movement of the tooth, and there will be proximal drift, and this can also be considered as a post-eruptive phase movements. Now in the post-eruptive phase, that is, the tooth is moving from the bony crypt into the oral cavity, there are theories of eruption which comes under it. There are many theories. I have included 5 theories which is more important. The first theory what I would deal with is the root formation theory. So the root formation theory is very simple, that it is initiated by the formation of the root, and as the elongation of the root happens, the tooth starts erupting. So whenever there is a theory proposed by someone, there will be 2 things one will be supporting the theory, and the second will be the which is contradicting the theory, or which can be called as against. So the factors that can be suggested which is putting down the theory is rootless teeth. For example, the experiments I have done where the root of the tooth has been removed or excised and the tooth still preferred to erupt into the oral cavity, which is against this theory, which put down this theory. Next is pulp theory. Pulp theory suggests there is a pulp within the tooth, and there is a pressure which is developing as the pulp proliferate. So when this pulp proliferate, the pressure is exerted downwards or apically. This will in turn push the tooth out of the bony crypt, that is resulting in the eruption of the tooth. So in this, there is a factor that was proposed against this theory, that is, a tooth which is pulpless also shows eruption with the normal procedure. So when you don't have a pulp also, it results in the eruption of a tooth. So this picture which I have shown in this slide is what is called hammock ligament theory. So it's an imaginary ligament which is present under the root, where the pressure of the growing pulp is exerted, whereas this ligament exerts an opposite or equivalent opposite force towards the tooth, which will result in the eruption of the tooth. So this is another theory called hammock ligament. So this is an imaginary ligament that is present at the apex of the tooth. Now coming to the next theory, that is bone remodeling theory. So according to bone remodeling theory, it is a pre-programmed procedure or a pre-programmed thing that is happening of eruption, where there is a bone remodeling that is already programmed. There is eruption of there is resorption of bone which is present occlusally, whereas there is deposition of bone apically, result in the axial movement of the tooth. This theory is supported by a fact that there is eruption of metal replica of the tooth buds. So I'll explain that. The experiments were conducted by replacing a tooth with a metal implant or a metal replica, and this even the metal replica also resulted in the eruption, even though it's not a natural tooth. So that is more of a responsibility of a bone to make the tooth erupt into the oral cavity than by the tooth itself. So that is a bone remodeling theory. Next is periodontal ligament traction theory. As we have already know, there are multiple types of periodontal ligament which can exert a traction force onto the tooth bud. So there is a contractile collagen fibers and fibroblast within the periodontal ligament, which can exert a force on the tooth bud, which will eventually result in the eruption of the tooth. So there is a factor that supports this. Experiments have proved that there is contractility of the fibroblast demonstrated in vitro. So the experiment went like, the fibroblasts were isolated from the oral cavity and it was incorporated onto the rubber sheets, small rubber sheets, and as the fibroblasts were proliferating, there is contraction or the bending of the rubber sheet, which was evidently shown or the experimented or demonstrated as there is contractility of the collagen fibers and fibroblast within the tooth socket. So that is periodontal ligament traction theory. In this picture you can see there is periodontal ligaments which is present on the mesial and distals as well as at the periphery of the tooth, which will result in the traction of the tooth and the tooth moves in the occlusal direction. So last theory is somewhat different from all these theory. Instead of giving the responsibility of the eruption to the tooth or the bone or the periodontal ligament, this is saying that there is factors which are present in the body which will result in the eruption of the tooth. So this is called as molecular theory. There are few factors that is involved in the molecular theory. First is EGF, that is epidermal growth factor, TGF alpha, that is transforming growth factor, and CSF1, that is colony stimulating factor. So these are the factors internally which will coordinate all these theories which you have already seen, that is bone, tooth and the periodontal ligament. These factors coordinate all of these factors together and the tooth is led to erupt into the oral cavity, and this theory rules out all other theories. So this is a molecular theory. Now when you deal with the eruption and post-eruption, there is three terms that I would like to explain, that is active eruption, passive eruption, and along with that there is anatomical crown and a clinical crown. So first I will tell about the active eruption, that is the bodily movement of the tooth from the site of development to the functional position. That is active movement, that is the tooth is moving and the position is changing. Whereas passive eruption is apparent lengthening of the crown, that can be because of the recession of the gingiva or it can be because of the recession of the bone. So when there is a recession of gingiva or recession of the bone, this will result in the increase in the length of the crown and it can be called as a apparent lengthening. So based on this factor, what you need to know is anatomical crown and clinical crown. When you see this picture which is on the right side, that is three pictures what you will see. The first picture, the anatomical crown, that is the anatomical crown is the length of the crown according to the dimensions, whereas clinical crown is the crown that is visible in the oral cavity. So in the first picture, the clinical crown, that is the crown which is present above the gingival margin, it is smaller than the actual length of the crown, that is the clinical crown is smaller than the anatomical crown. Whereas you see in the second picture, there is gingiva is at the normal position, the tooth is in the normal occlusion and you can see the anatomical crown is similar or equal to the clinical crown length. So it's both is equal. Whereas in the case of the third picture, you will see there is some sort of a bone resorption and based on that, there is resorption of the gingiva. So what you will see that is the clinical crown is longer or larger than the anatomical crown. So that has resulted in the apparent lengthening of the crown. So these are the three pictures where the first picture shows the clinical crown is smaller than the anatomical. Second one shows the clinical crown is equal to the anatomical crown, whereas the third picture shows the clinical crown is longer than the anatomical crown. So that is active and passive eruption. Next, coming to the next part of this class is sequence of eruption. When you see the permanent and deciduous, the sequence of eruption is the first thing that you need to understand. Then you can understand or by heart the proper time or the year wise or the month wise or the week wise eruption of the tooth. When you understand the sequence of eruption, it will be easy to understand the proper days or months of eruption. So in the primary, the eruption pattern goes like A, B, D, C, E, that is central incisor, lateral incisor, first molar, then canine and then the second deciduous molar. Whereas when you see in permanent, there is difference in the maxillary pattern of eruption or sequence of eruption, and mandible it is different. When you see in the maxilla, the first tooth to erupt in the oral cavity is the permanent first molar. That is permanent first maxillary molar. Then will be the central incisor, lateral incisor. Now there starts a difference. There is a first premolar erupting into the oral cavity, then second premolar erupting, then there is a canine eruption and followed by the second molar eruption. So when you see in this, there is a discrepancy, and the tooth has to erupt that is last is the canine. So when you see in a patient which is of age of 11 to 12 or 13, 14 years, mostly the blocked out tooth or which is out of the arch will be canines, because that is the tooth which has to erupt at the last. Whereas in the mandible, it is more or less same as that of, it is going in a sequence, that is mandible, the first molar, first tooth to erupt is the first permanent molar, next is central incisor, lateral incisor, then there is canine eruption, first premolar, second premolar, and the second molar. So in mandible it is of a more in a proper way, whereas in the maxilla there is a shuffling of the sequence of eruption. So when you understand this, then the next slide, when you see the permanent teeth eruption chart, you will understand it better. For example, when you see it, the first tooth to erupt is the first molar, then will be the lower central incisors, then will be the upper central, then will be the lower lateral, followed by the upper lateral, and then followed by lower canine. So this is the easiest way to understand how the tooth erupt. If you know the sequence, then you can by heart the 6 to 7, 7 to 8, 8 to 9, and 9 to 10, 11 to 12 years in a proper order. So that is a sequence of eruption in the permanent tooth. Now coming to the next part of this lecture, that is shedding. Shedding is the exfoliation or the removal of the deciduous tooth from the socket so that it will provide the space for the permanent successor to come. So it can be defined as a physiological process that results in the complete elimination of the deciduous dentition by within the age group. Now it is done by few processes, by the progressive resorption of the root. For example, if there is a normal resorption of the roots of the deciduous tooth, this will result in the mobility of the tooth, and there is a normal shedding of the tooth. Next is a permanent successor, that is a presence of a permanent successor is very necessary for the normal shedding or the resorption of the deciduous predecessor. So for example, if you have a patient where there is a congenital missing permanent successor, the shedding of the deciduous predecessor will be delayed for sure. So there, to initiate the normal resorption of a deciduous teeth, which will result eventually in the shedding of the deciduous tooth, you need to have a permanent successor under the tooth. So the resorption starts, even though it's at the apex of the deciduous tooth, there is few pattern for it, and it depends upon the presence of permanent successor. I have already told the permanent successor in the first few slides. I have told that the permanent successor of the primary anteriors is present lingually, whereas premolars is present just below the roots under the furcation, whereas for the distal, so for the molars, it is the buds are present distal to the tooth. So the resorption is start based on the presence of the permanent tooth, but for that the anterior, the resorption starts lingually because the tooth bud is present lingual, whereas the molars, the resorption starts in the inner surface of the root, that is from the apical region. For in this you can see in the radiograph the second permanent premolar, so second permanent molar is second premolar is erupting, so it is causing a resorption in the second deciduous molar distal root. So there is inner surface of the distal root is resorbing. As and when the distal root is resorbed, result in the mesial root resorption. Finally, the tooth will have a pre-shedding mobility, and the deciduous tooth will erupt, and the premolar will come into its position. So that's how the normal shedding process of a deciduous tooth happen, and a successor is coming. So these are the factors that has to be dealt under dental anatomy and histology for eruption and shedding and the chronology of the tooth. So we will look into some questions that is very important, and they will be surely asked in the university exams, which include some 10-mark questions and 5-mark and 2-mark question. So eruption and shedding, it as a general full topic, it's a 10-mark question which will include the eruption, which I showed about the pre-eruptive, eruptive and post-eruptive phases and the stages under it. including the theories of eruption, whereas it should also include the shedding, how the shedding occurs and the pattern of shedding with the diagram supporting to it. So that is a 10-mark question, whereas in the theories of eruption will as such be a question for 5 marks, where all the theories of eruption should be dealt with. There are multiple theories, but the important theories which I have mentioned, that should be there. Over that you can add how many ever theories you want. Next few 2 marks question will be there. Any individual theories of eruption can be asked as a 2-mark question. So these questions, when you understand by for the exam point of view, you will be able to write in that aspect and you can prepare in that way. So this is the class on eruption and shedding, as well as chronology or the sequence of eruption. So please go through these questions and it will be helpful for the exams. Thank you for your attention.